Well, Cara Santa Maria, it's just a fun name to say. Apparently, many people don't know this. She was going to be a nun, and that's how she got her last. And that's not true.
That's not true.
But the resume, the resume is a little exhaustive, right? It's got a lot. But something you may not know is she's an avid card player. And later tonight at 2 a.m., we're going to be having a Go Fish tournament where you can hear her say, "Do you have a 6?" Come on up.
I know nothing of this Go Fish. Oh yeah, that looks right. I think, maybe.
There it is.
There it is. I'm going to stand here, so I may pick this up, I may not. There was a lot of back and forth about, I wasn't sure what I wanted to talk about during this conference. Originally, you know, everything's been kind of frazzled for me, and so I was like, oh, I'll just talk about my dissertation. I already have a talk kind of about that, and my dissertation was on medical aid in dying, and then I realized, like, that's kind of a bummer to close out the conference. But also, here in Canada, your access to medical aid in dying is so much better than it is in the US. You can have physician administered, you can even have nurse practitioner administered, and I kind of realized that maybe as an audience, you are more informed than my general American audiences, so I wanted to pick something else that maybe, you know, we could learn something from. So a few things, even before I start the talk, kind of piggybacking off the last talk. It's funny because I had a David Dunning quote in my talk that I took out. Not for this, but I just randomly had already taken it out. And so I'm going to pick this up. I can't tell sometimes if this is like interacting with this. That might be the humming. So do you guys hear a hum?
Yeah, sometimes.
Sometimes, right? And I think that might be why, but I'll try and keep it on this side. So I can't show you the quote, but I'm going to read it to you. It is, and it goes exactly to, I think the point of the fact that as skeptics sometimes we work really hard to try and get to the heart of these issues and to debunk and to understand like the science in as pure a way we can. I'm going to be talking a lot about constructivism, so I'm going to kind of push back against that. But that even if the Dunning-Kruger effect is actually something different or it's not a real psychological effect, a lot of the work that David Dunning and his student Kruger did together, I think, still is really important. And this quote is exactly to the point that was made earlier, that it's not about ignorance, it's about misinformation. So Dunning said, an ignorant mind is precisely not a spotless, empty vessel, but one that's filled with the clutter of irrelevant or misleading life experiences, theories, facts, intuitions, strategies, algorithms, heuristics, metaphors, and hunches that regrettably have the look and feel of useful and accurate knowledge. And I think for that, even if the Dunning-Kruger effect is not real, we can be thankful for the work of Dr. Dunning. All right, so I decided that today, I don't know, I'm not liking this, I'm going to put it here. I can't tell if I'm too loud like Hemant was this morning. Hemant, where are you? You have a loud voice. It's painful. I don't want to do that to you guys. But so I figured that I would talk today about existential psychology. This is a really interesting topic. It's something that is near and dear to my heart. It's also something that I'm still kind of working out the best way to present. So what I would love for you all to do is, I almost said y'all. Do you say y'all here? No, you don't at all, do you? You say herbs. It's very different, which to me is strange because I get the British influence, but why not the French influence, right? We say herb in the United States because it's a French word. Herbe, like help, like this is how they say help, right? When you're speaking French. So don't a lot of you speak French? I'm very confused by this. Anyway, we can talk about it later. So okay, here we go. Numlock. Wait, how do I click? Can I just do the arrows?
Yeah.
But doesn't the clicker make weird noise? Oh, okay. Okay, so an intro for anybody who doesn't know, and that's okay. So I'm Cara Santa Maria. I was raised Mormon. I've done a lot of interviews about that. I'm not going to be talking about that today. I left the church when I was about 15, came out as atheist to my family. I found atheism long before I found science. Then I went to school actually to study vocal jazz performance, because that was my thing. Realized that once it was academic, I didn't enjoy it anymore. got a psychology degree because it was the easiest thing to like pull off at the last minute. But in that pursuit, realized how interesting psychology and the brain and human behavior were. I was actually a psychology philosophy major, and then I did my master's degree in neuroscience, and then I became a full-time science communicator. So I did a lot of SciComm through writing, not my favorite medium, mostly television, which just comes like slightly more naturally to me, and podcasting, of course. And only recently did I finally finish my PhD. I did a master's along the way in clinical psychology and now my PhD in clinical psychology. So a couple things here, yay. So this is my podcast, Talk Nerdy, which I've been doing now for, I just hit my 500th episode like last week. Yay, thanks. And it's a really good AMA with like Eli Bosnick. It's fun. Well, it's maybe not that funny, but he's funny. He makes it funny. And then SGU, of course. Yeah. I've been with them for like, I think almost the second half. They're coming up on, we are coming up on our 1000th episode. I joined them, so I started Talk Nerdy in 2014, and I joined the SGU in 2015. And Talk Nerdy takes 2 weeks off every year, the SGU doesn't. So maybe around 500 episodes, close to it with them, a little less. And then, I didn't put it up here, but I also have been helping my friend Eli out with his show, God Awful Movies. About once a month you can catch me on there where we watch a terrible Christian movie and skewer it. So I also co-wrote The Skeptic's Guide to the Universe book with my co-podcasters, the Rogues, as they call them. Oh no, I put another book in here and it went away. Oh, there it is. And more recently, I co-edited a book with Dr. Stephen Hupp about pseudoscience in therapy. And it's we kind of go through the DSM, and we asked for experts in the different kind of diagnostic categories to share their understandings of what is pseudoscientific, what has been debunked, what just doesn't have kind of a lot of evidence yet supporting it, but is in the in-between category, and then what are sort of gold standard evidence-based treatments. And I have some like critique on that in the intro, and we'll talk about that a little bit as well. So what do I do now? There's like a lot of words for what I do. Technically, my degree is in clinical psychology. I'm a clinical psychologist, but since I work at a hospital and I work with comorbidities, I'm also technically a health psychologist. I approach psychology from an existential perspective. That's going to be the second half of the talk. So what I'm hoping to do is be good at time management, and when we get halfway through where I've talked about philosophy, maybe open up to some questions that you'll be texting, and Jana Lee will ask them, and then I'll move into the psychology component, because like it's hard to understand what an existential psychologist does if you don't know much about existential philosophy. That's the foundation. Also, I take real issue with the term psycho-oncologist. It makes no sense to me. I should be an onco-psychologist, right? Doesn't that make more? I'm not an oncologist. I'm not a cancer doctor. But this is the term that they've chosen. So I do psycho-oncology, onco-psychology. I work at Cedars-Sinai, which is a large hospital in Los Angeles. I do consultation liaison psychology under the psychiatry unit, which means that 1 day a week I go bedside with individuals who need a psych consult for any thing. I see people with severe anorexia, amputations, really difficult illnesses. And then the rest of the week I do outpatient therapy, mostly in the cancer center, a little bit in the cardiomyopathy unit. So that's like the heart failure. A lot of them are waiting for heart transplants. And so I work a lot in end of life as well. That's kind of my core interest and my specialty. But I also work with people who are in survivorship or newly diagnosed who have a very, very good prognosis, but are just dealing with the experience of having cancer. If you listen to my show, you know that 2 years ago, before I did my internship to finish my PhD, as I was working in the cancer center, I was diagnosed with cancer, which was, of course. And so now I have this kind of new, I was very lucky. It was very early stage. I was able to have surgery, but did not need chemo or radiation. But that gave me a little bit of my own insight into what some of my patients have gone through. Okay, so first question is psychology of science. Yes. Spoiler. But I do hear sometimes some of the more kind of logical positivist skeptics, like some of the folks who tend on like I think the side of skepticism that I'm not on. Did I drop something? Oh, thank you. Sorry, I I changed because it was hot. Sometimes I hear those folks talking about psychology as if it is not a science. We know that psychology is a science. I have a PhD in it. I had to write a dissertation. And there are a lot of different types of psychology, and I think sometimes when we think about psychology, we just think about like clinical psychology, which, you know, unfortunately the bias is that's what I am. But there are so many different types of psychology. We've got experimental psychology, which is kind of how the field started. We've obviously got social psychology, IO psychology, that's industrial, organizational, developmental, forensic, so many different types. So, yes, spoiler, it's a science. We can argue about that later if you want, but I don't want to get into it. Okay. Next, so so when it comes to clinical psychology, one of the things that I dig deep into the literature on is Wampold's common factors theory, which we'll get to in a second. It first started in 1936 as the dodo bird hypothesis. This was really early, and actually it was kind of not a positive thing at the time, by Saul Rosenweg. And he said, you know, based on Lewis Carroll's book, The Dodo Bird, everybody has one and all must have prizes. That sort of like, why is it that there's so many different ways that people do psychology? Which ones work, which ones don't? And like, is this better than that? Is this approach better than that? How do we know? Well, cut forward to the 1970s and beyond, when a lot of research was done that showed like, why is the efficacy kind of the same across the board? And what we realized was that there are common factors, as described by Wampold, that seem to underlie good outcomes in psychotherapy. So psychotherapy tends to work if and only if bona fide approaches are utilized. That doesn't necessarily mean things that are always evidence-based, even though we love our evidence-based approaches. It just means not using pseudoscience in psychotherapy. And if the therapists have underlying traits that were kind of first described by Carl Rogers. So we're talking about things like empathy, unconditional positive regard, non-judgmental stance. If you're working with a therapist who strives to utilize that approach in therapy, that seems to have more weight. It carries more variance in the outcomes than the specific therapy that's being used. So that's like a really interesting takeaway from the common factors theory. Okay, so obviously we've got to ask though, are there times when different approaches work better? And the answer is yes. Like with specific diagnoses, we know based on the literature that different approaches can work better. Unfortunately, and I'm going to keep coming back to this, the literature is too clean. And this is something that we see a lot with human behavior literature. So studies on the efficacy of some sort of evidence-based intervention for depression will be on a group of people who have depression and depression only. And that is not reflective of reality, because very few people only have depression but don't also have anxiety or some other comorbidity. And so the problem is the ecological validity with a lot of these different scientific approaches. I think that they give us a really good kind of smorgasbord of tools. That's a mixed metaphor, but they give us a whole lot of tools that we can have in our toolbox. But a good psychologist, counselor, clinician knows that they're going to be adapting their approach to the needs of their client, and they're not going to be checking boxes and like be super manualized in their approach. That's what the science looks like. That doesn't always translate to reality. Enter existential therapy, because one of the questions that I grapple with when I dig into this type of literature is, do a lot of these evidence-based approaches, which tend to be on the CBT side, do they get to the root of the problem, or do they just help with symptom reduction? You know, are we taking a Tylenol to reduce our headache, or are we getting into why is the headache forming in the first place, right? And so these are interesting questions that neurologists deal with as well. And sometimes that's good. We want to get rid of the symptoms so that we can do some of the deeper work. Not sometimes, always that's good. I use CBT every day. Okay, so what is existential psychology? Well, in order to understand that, we first have to dig into what is existential philosophy? Just want to keep an eye on time. I'm kind of speeding through. I need to slow down. Hopefully you guys have questions. Start texting the questions. Okay. So I'm going to close this because it's distracting me. So I just have to stand here because I'm not tall. Can I turn this? Ooh, tell me if it gets unplugged. We're good. We're good. Okay. So how do we define philosophy? I don't know. Look at this. Can you? I still don't know. Philosophy is tough, right? Is it a discipline? Is it a process? Is it an encounter? Like I have a PhD. This was actually really funny when I first got hired at Cedars. They were very confused because Cedars is very medically oriented, and there's only a handful of psychologists on staff there, and so they don't understand they're like, you're a researcher, and I was like, no, I'm a clinician. I'm like, why do you have a PhD? Like, 'cause that's how it works. And so literally they were like, but we need to see that you studied psychology, and you're telling us you have a doctor of philosophy. And I was like, yes, in psychology. It was very confusing. But you think about it, like this was the original sort of doctorate degree, was a doctor of philosophy, and then we would specialize in different regions. It's a word cloud. Who loves word clouds? When we look at the Greek, like the sort of etymology, which I love, it really comes from this early meaning that's like philo or philo means loving, right? Yeah, we know. And then sophist, wise or learned. So really it's about the love of knowledge, or the love of wisdom. And so there have been a lot of attempts over this is like so heady. I just did it for shock value. There have been, memorize this, we're going to be quizzed on it later. There have been a lot of attempts to map out the history of philosophy over the years, most of them Western philosophy. There's some inclusion of Eastern stuff here. And so I just have some examples of like, where did it start? Where does it end? It's very confusing. It's a lot of big data analysis. And different attempts to sort of use taxonomy to try and make sense of it. And if you listen to my show, you know that I am often sort of questioning taxonomic constructs. Like we as a species really like putting things into boxes and putting labels on things, but these are all constructs to help us make sense of the world. None of these are the natural order of things. This is just how we try to divvy it up. So you can see here, there's lots of different approaches like metaphysics, epistemology, and axiology. Wait, axiology is too much, so we're gonna split it out and say logic and ethics and aesthetics. Oh, we gotta add politics there. Oh, there's too many. So there's a lot of different ways that we've tried to figure out how we know what we know, epistemology, why we make the decisions that we make, and so on. And so none of these are right. They're all just versions of each other. That one. Memorize that one. Okay, so what does existential mean? Well, okay, same thing. We don't really have a hard and fast definition here, but most people who relate to, are interested in, write about existentialism will say that it has something to do with existence, right? It's kind of in the name. The experience of existence, what it means to be alive, the amount of like freedom and responsibility that we possess in being alive. It was apparently the 2019 whatever dictionary this is word of the year of or relating to or characteristic of philosophical existentialism. Well, that's circular. That doesn't tell me anything. Concerned with the nature of human existence as determined by individuals' freely made choices. Well, that's one component of it. But yes, it's relating to existence. Okay. There are a lot of philosophers in existentialism. Many of them would, if you were to ask them today, are you an existentialist? They'd be like, absolutely not. But we see them as existentialists. So you've got, here is like, again, one attempt to categorize these philosophers of freedom, the phenomenologists. Phenomenology is super important. It's like a big part of my dissertation. The existentialists in the middle, the post-structuralists, the existential humanists. Some people like to call themselves humanists, not existentialists. There's a lot of crossover there. Is Kant on there? He might be on the next one. I'm telling you, there's a lot of these. No, Kant's not on here either. He would probably be pre-phenomenology though, I would think. Anyway, and so here I think is a more modern approach that is an attempt to, because if you notice, this is all, well, there's two women. Simone de Beauvoir, is she on here? Yeah, and Hannah. And then, but like, yeah, not a lot of diversity there. And so this is kind of a fun I did not author this. Popular existentialism over there is often split into Christian and atheism existentialism. And then we've got the I'm not an existentialists. Why'd you put me on this list? And then we've got black existentialism, which is kind of not newer. I mean, James Baldwin is often considered in that group. I read a lot of Baldwin. Sort of this is not just an individualistic movement, because a lot of existentialism is about like personal choice, personal responsibility, but there is a movement into the communal kind of view. How do you like this very long quote? I will read it to you so that you don't have to. This is me, the American, saying, Jean-Paul Sartre. Ooh, bad. He did a talk in 1945 that was then published in 1946 as a really small pamphlet called Existentialism is a Humanism. And I love this piece, and I think that it's very explanatory of a common atheist existentialist worldview. And he talks about a basic tenet, which happens to be tattooed on my foot. You can't see it, but existence precedes essence. And so he's going to describe it here. Atheistic existentialism, which I represent, states, after that in the ... is where he's like, and I'm right and everybody else is wrong, states that if God does not exist, there is at least one being in whom existence precedes essence. What do we mean here by existence precedes essence? We mean that people, this was written a long time ago, people first exist, they materialize in the world, encounter themselves, and only afterward define themselves. If people as existentialists conceive of them cannot be defined, it's because to begin with, they are nothing. They will not be anything until later, and then they will be what they make of themselves. Thus, there is no human nature, since there is no God to conceive of it. They are not only that which they conceive themselves to be, but that which they will themselves to be. That's an important existential idea there, will to power. And since they conceive of themselves only after they exist, just as they will themselves to be after being thrown into existence, people are nothing other than what they make of themselves. This is the first principle of existentialism. To me, that's very clear, but I've been steeped in this for a long time. So if it doesn't feel clear to you, I think one of the important components here is this concept of thrownness, and it's something that we talk about a lot. We did not confer with our parents before they made us, right? We had no choice in this matter. So we woke up alive. And when we woke up alive, it was then incumbent upon us to make sense of that. The idea here is that there is no such thing as human nature, even though there are core biological survival instincts that we have, rooting, coughing, things of that nature. For the most part, our choices, the way that we're shaped, the way that we think, are very heavily culture-bound, deeply culture-bound. And we exist in this sort of journey through our culture in which we're constantly making either overt decisions about how we want to be in the world and who we want to be in the world, or decisions that are often made for us because of the social pressures that we experience. But regardless of that, the idea here, which is a very atheistic existential view, is that there is no image of who we are to be. That is a choice that we make. So existence comes first, then our essence comes, as opposed to a very Christian view or a very religious view of existentialism, which is that essence comes before existence, that we're made in God's image, and therefore there's like a human nature that we follow. Is this making sense to everybody? Yeah? Okay, cool. Anybody, everybody, I said that together. Okay, so yeah, we've all seen this meme. It was funny in like 2019 when I first put it up here. Okay, so I want to take a quick break. I want to take a quick break to see if you don't have any questions, that's okay. But do you?
Could you go back to that slide again?
Yeah, oh sure, did I go through it too fast? Oh no, I'm sorry.
There.
I thought you'd all seen it. Sparkling anxiety. Okay, I didn't write that. So I want to take a quick break before we dive into what is Existential Psychology and see if there any questions have come up. Oh my gosh, and I'm so not an expert on existential philosophy, but maybe I can field some of these.
Just wondering if you think that existentialism is then compatible with the idea that, you know, there is no such thing as free will.
Oh yeah, so I just had Robert Sapolsky on my podcast. I guess I'm, have you guys like seen his new book? Okay, Determined, I think it's called. I think Robert is great. Like as somebody who studied psychology and kind of came up through that, we all read Why Zebras Don't Get Ulcers. I don't know if you guys are familiar with that, which is, it's a landmark book. Like everybody in psychology and neuroscience and actually just medicine has usually read that book about sort of, I mean, the title says it all, right? Like people, or I guess animals don't stay in an anxiety state for like a significant amount of time. Chronic stress is a very human experience, and it causes all sorts of health consequences. And he was one of the first to not one of the first to document it, but he wrote this really good tome about it. Since then, he's ventured a lot into philosophy. He's a primatologist and an endocrinologist, but he's ventured a lot into philosophy. He believes that free will does not exist. And so I had him on my podcast to talk about his newest book. I think that the moral argument that he makes and that he takes away from it is one that I fully agree with. It's sort of that, like, because there's so much that goes into shaping our experiences, like you can't help if you're born like poor. You can't help if you're born in a certain social class. And we know, at least in the United States, that social mobility is like nil. And so he's basically making the argument, his takeaway at the end is that because we can't control all of these things, like we shouldn't blame people for their choices, and we shouldn't put so much like, pull yourself up by your bootstraps, you wanted to be this way, this was all your choice. And I fully agree with that takeaway. I don't necessarily agree with how he gets there, and there's a word that he uses for people like me, like permissive, or I can't remember what it is, but it sounds insulting. And I think part of it is that the concept of free will is still like really poorly defined. And just like what we're going to talk about later about constructivism or even postmodernism, I think that a lot of people take the extreme version of that and they think about it in a very black and white way. So they're like, I'm very anti-constructivist thought, I'm very anti-postmodern thought. Of course there's an objective reality, but most constructivists are not like solipsists. They don't believe that they're inventing some sort of reality and there's nothing objective out there. We'll get to it, but their idea is that like it's all through our own filter. And I think with free will, it's an interesting thought experiment. We don't know. We're never going to know. And I think as a, I don't know if a lot of the existentialists really even grappled with whether or not that exists, because I think most, at least atheist existentialists that I've read, they fundamentally believe in free will because it's like a central tenet of their view. So I could be wrong, but it seems like free will is important to the equation of existentialism. There's probably someone out there who's an anti-free will existentialist. There are all types. Yeah.
There's a question here. I'm not sure if this is for now or maybe for later, but I'm going to just pose it to you. How do you see AI transforming the field of psychology? And do you have a guess for the impact and timelines of AI on the field?
I think that's a good question. We can probably field it now because I don't get into it in the second half. I think that there's space for it, just like there's space for AI in a lot of things. I mean, I'm of the view that AI is a really, really helpful tool, but like any tool, it can be used for, nefarious purposes or for humanity's good. And we're already seeing the development of a lot of AI. Sorry, I feel so bad. I'm making her like keep readjusting the camera back there. Can't see. We're already seeing the development of AI therapeutic tools. So sort of people like chatbots that people could talk to. I personally I wouldn't want to talk to a chatbot if I was in crisis, but it does seem to work for some people. I think that, informed consent matters, and so people need to know that they're talking to a chatbot, and if that's a choice that they make and it's consensual, I think that that's great. But I'm very, like, when I watch old therapy videos of Carl Rogers doing therapy, is anybody in here a psychologist or taken like any sort of clinical, I can tell you anything I want and you'll believe me. No, when I watch old videos of Carl Rogers doing therapy, so his person-centered approach was extra weird. And even though we've learned a lot from him, I would never want to get therapy from Carl Rogers because this is his approach. I'm really sad today. I hear that you're sad today. Yeah, I'm crying a lot. So you're crying a lot. And I'd be like, what are you, is this like, are you like punking me? Because he doesn't tell people in advance that that's what he does. I'm very different when I do therapy. I kind of like talk about how I do therapy and make sure that we're all on the same page. Anyway, that's a long, drawn out way to say that I think that there's space for AI, but just like one of the things that frustrates me about sort of our tendency in like Silicon Valley and in some of this startup culture is that, okay, we have this tool, how can we use it? I know, we'll use it to make art. Like, why? I want to use it to like do the parts of my job. Like, I want to use AI to do my charting so I can spend more time with my patients. You know what I mean? I want AI to help me with my chores so that I can make more art. And I think it's very strange that we tend to see like what kind of human creative endeavors can we see if we can dupe people with AI. It's like, no, that's just not, I think it's because we're in the early stages and it's proof of concept stuff and we want to see how far we can push it. But why are we so capitalistic that we're like, this is a great idea? No, help it do the bullshit part of my job so that I can do the part where I'm really holding space with people and connecting with people. I don't think a chatbot will ever be able to do that. I mean, that's a Turing test question. I think we'll be able to dupe some people, but is it interpersonal if it's not a person, right? Is it intersubjective if there's no subjectivity there from the, is it the mic? I think it's the mic. I'm gonna hold it this way. Okay. Yeah, so I don't know. Take from that what you will.
Thank you.
Of course. All right, so moving on. What does all of this have to do with mental health? I wrote my notes. No notes. Okay, so the first thing, I'm gonna miss some things and I'm gonna misspeak, I know, and I'm gonna make people who are advocates of certain orientations angry. Luckily, none of you are, I don't think. Oh, no, I shouldn't ask this. Answer in your head. How many of you have gone to therapy? Yeah, or out loud if you want. So even if you haven't been a practitioner, a mental health practitioner, you've probably been on the other side of that. And one of the things that I don't think we do well in our profession is describe to clients where we're coming from. And so this is a little kind of description of that. And maybe as you're listening, you'll be like, oh, my last therapist was so psychodynamic, now I get it. But there are a lot of theoretical orientations in psychology. Sometimes they're divided into these main 4. I went to a university where we divided them into 3. A lot of training models only train in CBT. And so that's not uncommon that people who get PhDs or PsyDs, I don't know what the convention is in Canada. Is it also PhD and PsyD, like a doctor of psychology? Yeah.
Except for Alberta, which you can have an MSc.
You know, yeah, and so we also do, so in the US there's a lot of master's level approaches. That's probably something I should talk about because I didn't put a slide in. But in the US there's a lot of master's level, so you can be like an LMFT, which is a licensed marriage and family therapist, or an LPC, which is a licensed professional counselor, or a LMSW, licensed mental health social worker. And there are some distinctions between like master's level mental health and doctorate level mental health. I mean, some of it is just the amount of time you're in school. Some of it is that there's a larger like research component given. But a big one, at least in the US, is that in order to do like psychometric assessment, and in order to do a lot of psychodiagnostic work, you usually are at the doctoral level. So a lot of master's level clinicians don't diagnose using the DSM. A lot of master's level clinicians don't do the deep dive like neuropsych evaluations or like the WACE, like intelligence tests, all those things, which are very loaded and there's a lot. But that's the thing, like at the doctoral level, because you have so much time, it usually takes 6 or 7 years, you can get deep into like the history of these tests and how they're kind of racist and how can we like interpret them with caution and all of these lovely things. I was also very lucky that I went to a social justice oriented school, and my concentration was in social justice and diversity, and so we approach kind of everything through that lens. Not all schools do. Not all schools do. So generally speaking, there are these major, but again, this is all categorization of theoretical orientations. There are a ton of others. You'll hear Gestalt, you'll hear multicultural, feminist, emotion-focused, like there are a lot of different approaches. But the main ones that we often think about are psychodynamic, existential humanistic, cognitive behavioral, and family systems. And let me see, did I include a timeline? No, I didn't. Wait. No, I didn't. Okay. And a lot of people, like when you're training in this, in history of psychology, they'll sort of graph that a lot of these are responses to previous sort of zeitgeists. So early on with Freud, it was very what we call psychoanalytic. Most people don't use that term anymore, psychoanalysis, it's a bit dated. The psychodynamic psychotherapists use a lot of what was learned from Freud, but they also like leave, like, you know, they don't like give their patients cocaine, and they don't call them hysterical anymore. And then there was this behaviorist response to that, which kind of like went all the way in the other direction. So like the talking cure and talking about your childhood and talking about object relations and you know, these different archetypes of people is kind of bullshit. So we want to look at stuff that's really evidence-based, and we're going to measure how you act, and then we're going to say this is an altered thought pattern, and we're going to work on the thought pattern, and once your behavior changes, we know that it worked, right? And that's where we get into sort of the cognitive behavioral stuff. And then you have these like third and fourth wave. All that's great, but I still think there's something more, and to me that's where existentialism came in, even though a lot of it came from these like really early philosophers and humanists as well. So one thing, and I mentioned this before, but I think it bears repeating, is that there's a really important distinction to be made between orientation and intervention. So all psychotherapists, all psychologists, and really all medical practitioners do case conceptualization, right? And it's kind of dehumanizing, it's really gross, like you're a case, I don't like that. You're a person. I do a very person-centered approach to case conceptualization. But the idea is you come to me, you tell me about what's going on with you, and I start to kind of say, how do I think about this person's life? How do I think about their mental health concerns? Why are they here? What do they relate to? What are some patterns that I see? And I start to conceptualize that case. And we do it for everyone we see as part of our dissertation, or not our dissertation, our qualifying exams. We do these big, intense case conceptualizations. I was very lucky that my big IQE case conceptualization was with a patient who was dying. When I was back at Cedars the first time as a student, I was working with this amazing woman who was only a little bit older than me. She had breast cancer with Mets to the kind of standard order, like spine, lung, then brain. And she'd been living with 10 years for breast cancer. And she was dying, and she knew she was dying, and we worked together. She had really severe depression, kind of beyond like an adjustment issue, historically, like a lot of ketamine trials and things like that. And we worked together a lot throughout her getting sicker and sicker, and then ultimately until she died. And I got to conceptualize her whole case, and I conceptualized her in a very existential way. So I tend to see people through an existential lens, and I tend to think about how I'm going to approach therapy with them through an existential lens. That's very different than what we actually do in the room. So interventions can be deeply manualized, they can be deeply evidence-based, and they can also get a little bit more into just like holding space, validating individuals, being present with them. All therapists do that. Some therapists do like manualized interventions, and I do sometimes. Like I have this great, anybody in here, there's a great workbook called the Anxiety Workbook for Men. And if you are a man and you are struggling with anxiety, it's a really good workbook because unfortunately most people who seek therapy are women. Like the overwhelming majority of people who seek therapy who want to, you know, like improve their emotional intelligence and work on their empathy are women. And so, and it's actually really interesting because a lot of times when you see women in therapy, you're working on things like boundaries, and a lot of times when you see men in therapy, you're working on things like empathy, which is very interesting. And it has a lot to do with like gender norms and how we're raised. But there are certain approaches that are evidence-based, like very CBT approaches. You'll hear about ACT sometimes, acceptance and commitment therapy. You'll hear about DBT, dialectical behavioral therapy. A lot of these things are deeply, deeply evidence-based, and they work. Like if I have a patient with borderline personality disorder who is dealing with a severe eating disorder, that patient probably needs DBT. Getting into an existential conversation with them is probably not warranted yet if they've never gone through any sort of psychotherapeutic intervention. And so it is really important that we know what they're coming at us with. We know how long they've been trying to work on their mental health, what medications are they taking. You'll also hear sometimes people talk about psychology, and I feel like this is like the social media woo of it all, like the pop psychology. Like, my job is to get you off your meds. That is bullshit. And if you ever hear somebody say that to you, I would recommend running out of their office. A lot of severe mental illnesses require medication, and my job is to work with your psychiatrist to ensure that you have, you know, a multifaceted, a multidisciplinary approach to your mental health. I think I'm lucky in that I'm a health psychologist, so I have the opportunity to do that. I can look in their chart, I know what they're taking, I can talk to their psychiatrists at the hospital. So anyway, I am an existential psychotherapist. I see my patients often through an existential lens. I just think about the world in an existential way, but that doesn't mean that all of my interventions are existential interventions. There's actually only like 2 or 3 really good evidence-based existential interventions. Most of existential psychology, I shouldn't say psychology, but most of existential therapy doesn't have a strong evidence base for it. And that's not because it's been debunked. It's not because it's pseudoscience. It's because it's not really testable. And I think that is a fundamental issue in the way that we do, in the way that we test psychotherapy, is that people think psychotherapy is like a drug, and it's not. And we see it through a medical model, and we want to do these randomized controlled trials and say that those are the gold standard. And while they are, and while we have a lot of really good evidence-based approaches, EMDR passes evidence-based, like the APA, the American Psychological Association, calls EMDR an evidence-based approach. And EMDR is bullshit, and we know it's bullshit. It's a purple hat. Have you guys heard about this before? Purple hat? Yes and no. Anyway, long story short, do you know what EMDR is? It's the idea that, like, if you move your eyes back and forth really fast while you talk about your trauma, like, you get better. And if you talk about your trauma, you get better. You don't have to move your eyes. And so, yeah, they call it a purple hat technique because it's like, I'm trying to remember the name of the guy. Ooh, I'm blanking. I'll come up with it, I'm sure. He basically talks about, there's a guy who writes about it really well in the book I edited. If I'm driving on a bridge and I have, phobia and I have panic when I go over a bridge, and I teach you a bunch of grounding exercises and diaphragmatic breathing and mindfulness approaches and all of these things to help with your anxiety and calm you down, you're gonna get across the bridge and you're like, oh, so much better this time. And then I'm gonna put a purple hat on you and be like, go forth. The purple hat worked. It's like, no, all the freaking therapy you did is what worked. And so there are a few things like that on paper look like they're evidence-based, which is a bummer. A lot of existential approaches just aren't manualizable. And so because we can't structure them in a way that you can do a randomized control trial, we can't, so you end up with this circular problem where the easiest things to test end up being the things that we say are evidence-based, and all of the stuff that is actually really difficult to test never gets tested. And so that's a complicating factor in psychotherapy. Sometimes, yes, the CBT is the gold standard, but I see a lot of people who've done it all, and they're still struggling. Or they're struggling with things that we just don't have evidence-based approaches for. And so, for me, enter existentialism. Okay, so, still haven't really told you what it is. Here are some of the influencers. You know why I haven't told you what it is? Because there's no definition. There's this great study that I often cite when I'm teaching about this by, like, Coria, I think is their name, Coria et al. And they're talking about, like, they sent out surveys to a bunch of people, and they were like, do you identify as an existentialist practitioner? And so they looked at all the ones that came back yes, and then they were like, okay, like, what does that mean to you? And, like, all the answers were different. So even that is not very standardized. But I will say, interestingly, I think I looked at a recent survey of US psychotherapists. I don't think it was just psychologists. So it did include a lot of like master's level, but licensed practitioners. And I think 3% of them identified as existential. So we in the minority. Here are some people who influence existential psychotherapy, but half of them wouldn't have called themselves existentialists. Maslow didn't. You guys know Maslow? Hierarchy of needs, all that stuff. Yeah, he was early on. Carl Rogers, I've talked about a little bit. Oh, that got loud. I read a lot of May and Bugenthal. And I love Emmy at the bottom. She has some weird ideas, but she does a lot of end-of-life stuff, which I really like. But the two people I want to kind of focus on are Irv Yalom and Viktor Frankl. So I'm going to start with Irv Yalom, even though he's closer to us in history. He's still alive. He has dementia now. He has really interesting stories online about his dementia. His wife recently died. She actually utilized medical aid in dying. She had cancer, and they co-wrote a book together called A Matter of Death and Life, and it's really, really beautiful. But he wrote like the textbook that a lot of people use when we talk about existential psychotherapy. And just doing a time check. Cool. And so in it, he kind of breaks down what he calls 4 givens of existence. And the idea here is that although there are examples of like overwhelmingly neurologically based mental illnesses, like schizophrenia, like bipolar disorder, and also like a lot of neurodivergence, like ADHD or autism spectrum disorders, a lot of people who seek therapy, who are dealing with what they historically would call the neuroses, not the psychoses, a lot of people who are seeking therapy are coming to therapy because they're like dealing with some shit. Well, what are they dealing with? His argument is that there are these 4 givens of existence that all people have to grapple with. The first one is fear of death. Nobody is not going to die. And that prospect can be really overwhelming for a lot of people. Some people just kind of don't think about it. Some people just kind of think they're immortal. But we all know we're going to die. I work with a group of people for whom death is more, I often use the metaphor of a clock. Like we all have a clock on our wall, we don't know how long we have, and for a lot of my patients, it's just ticking a little bit louder. And so he talks about these different ways that people deal with fear of death. He talks about belief in personal acceptance, like not personal acceptance, like personal exception, like, well, I'm not going to die. You might die, but I'm not going to die. I don't have to think about it. But another big one that he talks about is being saved, like belief in a savior. And for some people that's religion, for some people that's their therapist, but a lot of people have this cognitive ability to sort of come up with a way that they don't have to worry about this. Every time I see a new patient in my intake, I ask them about these 4 things, and I ask them to rate themselves on a Likert scale, on a scale of 1 to 10. How much are you bothered by? How much do you find yourself grappling with? How much do you have anxiety about or depression about fear of death? And some of my patients are like, it's a 1 or a 2. I know it's coming. It might be a kindness at this point. Some of my patients are like 9 and 10. It keeps me up every night. I'm freaking out. I can't talk to any about it. That's really important for me to know, right? It's really important for me to sort of center how I'm going to approach them. The next one is loneliness. We are people. We are a social species, and we all struggle with loneliness at some point in time in our lives. Now, for some people, this is salient. For others, it's not. That's why some people seek therapy. For others, that's not an issue in their life, or at least not right now. Meaninglessness, because the existentialists are like super into bumming everybody out. They don't say meaning, they say meaninglessness. It's like, really? I'm gonna talk about Viktor Frankl next, but he made a whole therapy called logotherapy based on meaning. And then finally, freedom and responsibility. I had to take out the space so it would all fit in one line. Yalom has an interesting approach, and actually most existentialists have an interesting approach to freedom and responsibility, because we kind of talk about it like it's the same thing. We're free to be responsible. Like the more freedom you have, the more you're responsible for yourself. So in some ways, like, right, slavery and bondage is something that we absolutely don't want. But when you are fully enslaved, when you are fully in bondage, you don't make a lot of decisions for yourself, and you don't have a lot of responsibility. And so this becomes a really important concept with a lot of my patients who are dealing with burden. in end of life or just in a life-limiting illness. So the next person that I utilize a lot, and this is where we see some evidence-based approaches are often based on Viktor Frankl. So he wrote this book, Man's Search for Meaning. He was a Holocaust survivor. He was in Auschwitz and literally lost his entire family and all of his friends. He was Jewish. He's actually not secular. He was Jewish and a believer. And so he sort of talks about meaning in an interesting way, but allows for meaning in a secular way. So one of the big takeaways that I often will talk to my patients, because some of my patients are very religious, and it's not my job as an atheist to be like, God doesn't exist. Doesn't that comfort you? You know, it's like I take their frame. But the idea, well, first of all, logotherapy, which is what he developed, comes from the Greek logos, meaning meaning. So it's just meaning-focused therapy. This whole approach is to help people who are struggling with meaning identify sources of meaning and purpose and legacy. And there are a lot of spin-off therapies that have come from it. So his view is that there is meaning in the world because God put it there, right? Like he's religious, so he thinks that there is an imbued meaning in things and it's our job to like find it and extract it. But the atheist view still has the same outcome, which is that, okay, there is no implicit or imbued meaning, but like an artist, it's my role to create it in life. And you end up with the same outcome. And so for me, whether somebody is religious or not religious, when I'm treating them, doesn't really affect how effective this approach is, because you can always frame it in a way that is meaningful for people. So here's a quote from Viktor Frankl. Everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. And this is sort of a big takeaway from his book. He was a man who had everything taken from him. You know, he was living in a concentration camp and watching people die around him. And one of the questions he asked was like, why am I still here? What do I have to hold on to at this point when everything I know and love is gone? And he worked deep, you know, it's not like this therapy was developed out of his experience at Auschwitz. He was already a psychologist when he went in, but it was sort of codified for him, kind of like honed, because he realized that the thing that was keeping him alive and keeping him sane in that situation was that he could choose his attitude. Like it was his last freedom. And it was really empowering for him. And this can be very empowering for people who are very, very sick. My view is that, you know, I'm not like a positive psychologist, and I actually talk a lot about like the power of positive thinking and, you know, the secret and how detrimental it is, because obviously the flip side of if you stay positive, you'll live is that, oops, I didn't stay positive enough, that's why cancer killed me. And that's not good, right? We don't want people to have that takeaway. It's also not reflective of reality. So my view is it's really about authenticity. Finding how do you actually feel and allowing yourself to feel that way. Tapping into what's meaningful for you. Tapping into what attitude works for you, but that's yours and yours alone. You know, a lot of existentialists will say nobody can birth your birth and nobody can die your death. This is a fundamentally individual experience. You can have people around supporting you and loving you, and I hope you do, but ultimately nobody's going to die your death for you. It's something that you have to face. So the last thing I want to bring up here in the last few minutes is this idea of logical positivism versus constructivism. And if you look back, I'm going to go through like a million of these really fast, to some of the philosophy, was it this one? No. Charts, like here. You can kind of see existentialism and phenomenology way down here, and you see logical positivism way up there. One thing that I often find is that individuals who identify as skeptics fall subject, we all fall subject because we do not have the neuropsychological humility that we're all always working towards, right? But we all fall subject to cognitive biases. And one cognitive bias that I see like from a mile away in a lot of skeptical rooms is black and white thinking. And I find that a lot of skeptics identify, without knowing what it's called, with a logical positivist worldview, which is basically that There is nothing except the things that are testable. If I can't test it and get a rock solid answer, then, and I'm paraphrasing, this is not just what the logical positivists believe, but like if it is untestable, if I can't get a rock solid answer from it and I can show you that it's like sea lioning the world, right? Like, but where's the evidence? But where's the evidence? And in it, they forget about things like moral philosophy. And they feel, like I literally just got an email today to the Skeptic's Guide from a listener, because we were talking about the Molly Malone statue. I don't know if you guys listened last week, but we were talking about the Molly Malone statue in Ireland. Jay just got back from Ireland. And the Molly Malone statue in Ireland's breasts have turned a different color because people rub them for good luck. And there's a huge movement that like sexually assaulting a statue, it does not set a good precedent for your children. It is reflective of a society that objectifies women, and it's something that we should really be talking about more and not just laughing off. And I just got an email from somebody who's like, stop moralizing on the show. You're always moralizing. And they're like, I come to the show just for science. And it's like, well, sorry, science happens in the world, and science is done by people. And I think that there is room for moral philosophy. And I think that if we try to completely remove, it's like you see that argument that like, this is logical, not emotional. You're being emotional, but I'm being logical, so I have the higher ground. And it's like, or maybe this doesn't apply to you because you have privilege. And maybe that's why you're not getting upset when you're having this conversation. Because you've been a privileged white man, and Roe v. Wade doesn't affect you. And when you're trying to tell a woman, blah, 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 and she's crying, she's emotional and she's not thinking with logic, or she's thinking about how she's actually affected by this, right? And so I think that one of the issues that I find a lot with this sort of like intense logical positivist view and this sort of anti-constructivist view, and just to semi-define constructivism, it's the idea that many constructivists believe there is an objective reality. Some very extreme constructivists don't. But I would consider myself a constructivist, and I 100% think that there's objective reality. But I also think that the human experience is such that we're always approximating it. We utilize the scientific method to try to get as close to reality as possible. We use measurement tools to try and get as close to it as possible. And that's why a lot of people feel like on solid ground when they talk about physics. I like physics because it's got laws. But even physics is like, oh, what about superposition? This is very confusing. Are there strings? I don't think so, but maybe. And so constructivism is the view that like everybody has their own interpretation of reality. And that interpretation is shaped by their experience, by their belief systems, by how they were raised, by their privileges, by their lack of privilege, by their gender, by their race, by their ethnicity, all of these different things. And for me as a therapist, I realized early on in my training, if I don't have a constructivist view with my clients, I will not be an effective therapist. How can you be empathetic if you're not willing to try to take somebody's worldview? If you're not willing to at least practice seeing the world through their lens? And, maybe striving to have a more objective worldview to some people is a noble pursuit, but again, to me, that doesn't really have any ecological validity. I would rather look at the available evidence. I would rather utilize critical thinking, utilize the scientific method, and yet still understand that people are people and work within that frame. And I think that makes us more effective science communicators. I think it makes us more effective psychotherapists. And honestly, it makes us better friends. It makes us better in our relationships with our family, with our romantic partners. And so, I think as skeptical activists, we can learn a lot from the constructivist stance, and, be a little more open to it. So, so that's it. So do we have any more questions? Loads, she says. Oh no. And thanks for bearing with me as I bumble through this talk I've never given before. And kept to time, kind of. Okay.
No bumbling, it was great. What are your thoughts on MAID for people whose sole underlying condition is a mental illness?
Oh, I saw that that's really trending, because something was placed before your legislation, it got pushed back here. I have to speak carefully about this because in the US, oftentimes when we talk about MAID, we need to talk about what is legal. right? Because I'm not an advocate for like breaking the law. But there are places where physician-assisted dying and euthanasia are legal, and I think we might have seen some cases where mental health was out in front. Oh, I can't believe I'm about to say this publicly. Is this on the record? Yeah, there's like a video camera. Okay, I should be careful. I have a very different view of suicide than a lot of my colleagues. So the mental health kind of field is that at all costs, literally, like suicide is, most mental health practitioners, suicide is the worst thing that could happen to a client. It's the worst. And of course, I feel very, very strongly that preventable suicide should always be prevented. I've also seen some clients that have treatment-resistant depression, and for them, their depression was a fatal illness. And it was very sad. And it was a tragedy across the board. But for some of those patients, I don't think anybody along the way can really realistically say, I wish we would have done more, because they did everything. They tried multiple rounds of ECT, they tried TMS, they took every drug on the market, they did all of the therapies, and their brains fucked them. And it was really, really tragic. But my view is that like individuals with capacity should have a choice, an empowered choice. I get that the view oftentimes with mental health is that it's a capacity issue, right? And it's the same thing with dementia patients. It's why you can't do MAID with like advanced dementia in the US, because you don't have capacity to make that decision for yourself. But I will tell you, and maybe this is like the diplomatic way to say this, in the US, there's a long conversation about capacity assessment around medical aid in dying. Depression in and of itself is not something that would, like if a patient comes to you dying of cancer and saying, I want to use medical aid in dying, if they are depressed, that is not enough to say they don't have capacity. A depressed person can have capacity. They can still be empowered and choose this way out, but they also have to have a terminal illness. And so that's kind of the difference. And I know I sidestepped that a little, but that's what I gotta do.
I actually thought you handled it amazingly well.
Thank you. I still don't have my license. I don't want to not get my license. Working towards that.
In your work on grief, do you have favorite non-academic books on dealing with grief?
Oh, I have a really good one called The Grief Recovery Handbook. It's the one that I generally use. I'm not a big grief practitioner, but very often I'll have, like one year I remember having a bunch of patients that I was working with, and 3 women, all in their early 40s, all with breast cancer, all whose dad died in the last year. And I remember being like, what is going on? And so I had to really bone up on a lot of this stuff, because I don't usually do bereavement counseling. That's like a specialty. And it's funny, because when I tell people I work in end of life, they're like, oh, grief counselors or so. I'm like, no, I work with the person who's dying, like not the people who are around the person who's dying, which I guess is kind of rare. But I like the Grief Recovery Handbook because it has like a series of almost exercises. It's different than a standard workbook though. It's written in narrative form, like it's prose, but it has a series of exercises, and it ends with you writing a letter to, if it's a person, the person you lost. But there's an emphasis on other forms of grief in this handbook, like loss of religion is covered in the handbook, like loss of identity. And so I really like it because I think it kind of is multifaceted. So yeah, I recommend it to a lot of my patients. Yeah.
I'm not sure if you can answer this, but why do I feel so uneasy about the term trauma-informed therapist?
Oh, that's interesting. Probably because there's so much woo on the internet. I would think that's why, some people feel uneasy about certain terms. I think that it is important that therapists are trauma-informed, but I think it can also easily become a buzzword. So like, first and foremost, you need to be working with somebody who has credentials. You don't want to be working with like a life coach. It's funny because I just said I don't have my license yet, but that's because I'm a postdoc. I'm finishing the last things that I have to finish in order to get my license. A fellow, as they call it. Some therapists, whether that be like a master's level counselor or a doctorate level psychologist, don't get specialized training in trauma. So there are some therapists who specialize in PTSD and CPTSD, and they have trained, their whole lens is working with people who have dealt with sexual assault, intimate partner violence, gender-based violence, genocide, experience in traumatic, like, natural disasters. And they know where the woo is hiding, and they know what works, and they know how not to harm. And I think that the reason that we use the term trauma-informed therapy is because those people, like, if you really are dealing with severe trauma, it's very easy to be re-traumatized in therapy by a counselor who is not trained in, like, specifically trained in that. It's just like, I see patients with eating disorders in the hospital, but I would not be their outpatient therapist because it's not my specialty, and eating disorders are so specific and there's so much riding on them because it's one of the few, like, potentially fatal mental illnesses, that I want somebody whose whole life is working with eating disorder clients. And I think it's kind of the same thing. Like, hopefully everybody has some trauma lens, and I think we're moving towards the entire field going in that direction, but some people don't. That said, I hear the woo stuff because I think we have this pop psychology tendency to be like, that guy's breadcrumbing you, and ooh, attachment, like, what's your attachment style? And, you know, all of these things that, like, aren't very evidence-based, and sort of within the psychology community, we don't talk like that. And so when everybody's like, well, that's just my trauma, and their trauma is that, like, I don't know, they went through a breakup when they were a teenager. And so it's like, not to belittle anyone's experience, but there is a difference between post-traumatic stress disorder and having had hard stuff happen to you in your life. And if you've ever worked with somebody or seen somebody who has post-traumatic stress disorder, it's different. It's kind of like when people are like, I'm so OCD about that. Like, that's actually really insulting to somebody who struggles with constant obsessions. And so I think we do have to be careful with our language. I could do an entire hour about pathologizing and about the DSM and all of its problems. So we could talk about that offline. But yeah, I do think we have to be careful about that.
Yeah, thanks. And that word is bleeding into other adjacent professions. Like,
oh, right, like teaching.
Yeah.
And I think, it's like the same as, like, okay, like neurodivergence. Historically, autism spectrum disorders, previously Asperger's, which is now just on the spectrum of, like, needs minimal support to needs a lot of support, is it's real, right? And so I do think that, like, teachers need to be trained in how to work with students that have a neurodivergent brain. But at the same time, not everybody is on the spectrum. You know, and I think that we need to know the difference and not treat everybody like they're on the spectrum. And so it is really important to sort of be informed and have that lens, but then not apply it to everybody.
Thinking about your Frankel quote, you talked about people's attitudes being individualized and avoiding engaging in toxic positivity. Mm-hmm. Can you, as a therapist, help people to change their attitudes toward death or whatever, or do you just need to accept their attitude and work with them within that framework?
So my view is, and this is kind of the view of the DSM, the one part of the DSM that I sort of like, is that in every mental disorder in the DSM, except for, I think, narcissism and antisocial personality disorder, one of the specifiers for qualifying for that disorder is that it negatively interferes with either your work, your relationships, or your daily functioning. And that's a really important qualifier because everybody gets sad. Not everybody has depression. When do we diagnose certain things? When people are starting to feel so negatively affected that it's impacting their ability to do things. And so I think that that kind of is an important, can you just restate it again? Because I want to make sure I'm answering exactly what they asked, unless I made you delete it. I'm sorry. Okay. Oops. She's like, done.
Can you, as a therapist, help people to change their attitudes toward death, or do you just need to accept their attitude and work with them within that?
Right, so I would say the latter is true. I accept everybody where they are. I meet them where they are. And the former is also true because my question is, do you want to change this? So some people come to me and they're like, I'm so afraid of death. It's fucking with my life. And so that's something they want to work on. And so yes, we work on reducing the anxiety around that. I often will use the metaphor of like being in the attic. Do you guys have attics here? You do. Do you have basements? Yes. We don't have basements where I'm from. It's weird. Okay. It's weird. From Texas. There's like no basements in Texas. It's on bedrock. But like being in the attic and the lights are all off and there's like a mannequin or a pile of clothes in the corner, like, it's like a scary monster. And then you turn on the lights and, the more that we sort of shine the light on things, the more that we come to understand how they work. I read books, and some of my patients do, about, like, there's a book called How We Die, which is a graphic book about what happens to your body as you die, or as you get close to death. And for some people, it is really comforting to know exactly what's going to happen. For other people, it's not, and it's about understanding where they stand and how much of that light we want to shine. But ultimately, if somebody is saying, I am deeply afraid of death, it's like crippling me to the extent that I can't function in the world. I can't sleep at night without meds because my brain is just constantly thinking about it, or I'm afraid I'm going to die every time I go to sleep, and so I have to do all of these things to prepare for that. I've had patients like that, right? They have like letters they leave for their children, and because it's that, debilitating, they want to work on it, so we work on it. But that's up to them. Like, my view as a practitioner, and this is a big part of existential, or I'd say more humanistic approaches, is that I don't pathologize my patients at all. And I don't take this medical view that somebody came to me because they're broken or there's something wrong with them and I'm there to fix them. They are the experts in their own life. They come to me with a hope, with a goal, and we co-create, and I facilitate a path towards working on that mental health. But I don't cure them, and I don't prescribe to them, and that's always how I approach it.
Are you okay to take a few more?
Sure, why not? Are you guys okay with it? You're like, you really gotta pee, don't you? You can just pee if you need to. I won't be offended.
Is there a difference between a psychologist and a psychotherapist?
Yeah, so it depends, and again, like, I have to be careful because in the US, every state has different rules, but you can't call yourself a psychologist in the US. I think there may be one or two places where you can get a master's in psychology, but at least where I live in California, you can't legally call yourself a psychologist unless you have a doctorate degree in psychology. It's just like you can't call yourself a medical doctor unless you have an MD. You can call yourself a, like a physician's assistant or a nurse practitioner, but you can't say, I'm a doctor, even though you do doctory things. And psychology is the same way. Psychotherapist is a broader term. So people who do mental health therapy can call themselves psychotherapists, and we put psycho as the prefix because there's so many other types of therapy. Like, if you're in a hospital and you say, I'm a therapist, people are like, OT, PT, like, what do you do? Because those are all forms of therapy. So we say psychotherapy to differentiate, but like, psychotherapy is what I do, but psychologist is like what my title is on my badge. And I can call myself a psychotherapist too, but a master's level practitioner couldn't call themselves a psychologist, if that makes sense. Yeah, they would have to say, I'm a social worker, or I'm a licensed marriage and family therapist, or whatever their certification is. Yeah, and same thing I want to say with psychiatry and psychology, because a lot of people, I don't know if people in this room are confused by that, but a lot of my patients are, especially because my badge says psychology fellow, psychiatry, because that's the department I work in, which is very confusing. But psychiatrists are medical doctors, and they prescribe meds. They can also do therapy, but most of them don't because it's not as lucrative as doing a 15-minute med check. But they can prescribe meds. I don't have prescriptive authority. They are working towards prescriptive authority in some regions, but I do not prescribe medication because I'm not a physician. Yeah.
Okay, I got one more, which is a reference to god-awful movies.
Oh no.
Someone is asking, how does one go about becoming a dead person dentist?
A dead person dentist, yeah. So Eli is ruining my life. I actually had to text Eli Bosniak and say, you have to take down that website, because he has a tendency to prank war people by buying websites. Like, I don't know if you guys know Marsh, but Marsh did COVID is a website. And so Cara did 9/11 became one, which is real fun. And then when for those of you who don't know, I'm going to do a quick and dirty. We did an episode of God Awful Movies that was about a Scientology movie, like an anti-psychiatry Scientology movie. And in it, they made increasingly ludicrous claims about how psychiatry is like ruining the world. And so they blamed all these things on psychiatry. And at one point we were all like, oh, next they're gonna blame 9/11 on it. And they did. And so Eli kept making a synecdoche of me because I'm a mental health practitioner and being like, you did 9/11 throughout the episode. And then that stuck. And then he bought the website, Cara did 9/11. And then when my book, the book that I co-edited, which is like a serious academic book, came out, all the reviews on Amazon are like, jet fuel can't burn this book, and like it's bad. You know, and they'll be like, I was surprised by the chapter on antisocial personality disorder, especially because Cara did 9/11. And so now I'm like, ooh, this is like maybe venturing into like worrisome territory when I do become licensed. And people are going to be looking me up and they're like, oh, they don't want, yeah. So I made him take down one of the websites, which was drcarasantamaria.com, because another one of his inside jokes is that Eli doesn't understand mental health, which is ludicrous because he's a very smart guy. Is he knows that I work in end of life. And so he's like, you're a dead person dentist, right? Like he's always coming up with ridiculous, he's like, you like steal dead people's teeth? And I'm like, that is not what I do for a living. But it's become now so big that there was like a whole website that was like the best dead person dentist in town. I'm like, Eli, you have to take this down. Like people can't search Dr. Cara Santamaria and find this. So he did, but the SEO is still up there. Like I think if you Google like Cara Santamaria and a couple other things, like a lot of 9/11 dead people dentist stuff comes. So let's work to not have that happen. Might fuck me over professionally. It is funny though.
Thank you so much.
Thank you. Thanks everyone.
In the heart of reason, our voices unite. A sweet skipping saving, shining bright. Learning and sharing, our minds ablaze. No tinfoil hats, we wear skeptic berets. Forming bonds that we found on debating. At the WeCanReason conference, we're celebrating. Dr. Cara Santamaria, with words of the day. Skookum took off their knees in a playful way. Science or fiction, her victory's near. Dinosaurs